This is Dr. Abhishek Bansal from Rajiv Gandhi Cancer Institute and Research Center, New Delhi, India, and I bring warm greetings from this place. I'm thankful to the Oncology Club Bangladesh for providing me this opportunity to be a part of this virtual preceptorship program. And I'm especially thankful to Professor M.A. Hai, the president of the Oncology Club, Professor A.M.M. Shariful Alam, the Secretary General, and Professor Kamaluddin for giving me this opportunity. The topic that has been provided to me is state-of-the-art imaging of prostate cancer at diagnosis and advanced stages. What should be practiced? And hopefully after this presentation, I'll make this topic a little bit clear what really we should go ahead and practice. I'll take you back to 2008 at the annual American Urological Association Whitmore lecture. Dr. Patrick Walsh, a renowned uro-oncologist, mentioned the discovery that would have the greatest impact on our field would be the development of accurate imaging of tumor within the prostate. So we are actually trying to fill in this missing point so that we can actually put it all together. This is the magazine that is being published by the Johns Hopkins University from the Brady Urological Institute and a publication of the Patrick C. Walsh Prostate Cancer Research Fund. And this is a pretty recent publication, and the cover story talks about how advanced imaging, better biopsy, smarter treatment, and fewer side effects can make a difference to such patients. And apart from the traditional imaging discussions that I'm going to talk about in my presentation, what this cover story actually talks about is how even the urologists are changing their way of doing prostate biopsies, and they are moving from transrectal to the transperineal way of doing biopsies, and they are talking about that it leads to reduced infection rates and certain further advantages also. Well, this is from the NCCN website, and it says that it's easy to get lost in the cancer world, and let NCCN guidelines be your guide. Well, I would say that this is not just for patients, but for all allied fields of the oncology, such as a radiologist like me, or even other allied fields. We also refer to NCCN, and these help us to really understand what the oncologists are talking about, even in our routine day-to-day practice and tumor boards also. So straight away, I'll take you to 2021 guidelines, and it talks about the imaging for initial risk stratification and staging workup for clinically localized disease. And as per the risk group, the very low, low, intermediate, and high, and very high. In the very low and the low group, the multi-parametric MRI is only is plus minus to establish candidacy for active surveillance. For the high and the very high, they recommend that bone imaging should be recommended. The pelvic and the abdominal imaging is recommended. And in case regional or distant metastases are found, then I'll come on to it separately for the advanced diseases. For the intermediate group, they talk about multi-parametric MRI again to establish candidacy for active surveillance. Bone imaging is not recommended for staging for the favorable intermediate group ones. And again, pelvic and abdominal imaging is recommended if the nomogram predicts more than 10% probability of pelvic lymph nodes. And same for the unfavorable intermediate group, bone imaging is recommended if the lesion is T2 or PSA is more than 10. And again, similarly, pelvic and abdominal imaging recommended if nomogram predicts more than 10% probability of pelvic lymph node involvement. The index from NCCN of 2021 talks about principles of imaging, and they highlight the goals of imaging as for detection and characterization of the disease. And they have enlisted all the imaging hereby, but I would take you straight away to the, I would skip the radiography part of it and take you to the ultrasound. We know how transrectal ultrasound is used to guide biopsies. The bone imaging, we know the technetium-99 MDP bone scan is used for detecting bone metastases. And it talks about that bone scan is indicated in initial evaluation of patients for high risk of skeletal metastasis. This is important. Then coming on, this is a busy slide. I've taken it from NCCN, so I'll just briefly put the gist in front of you. So this all talks about how bone scan response, and so we'll skip that because I'll cover all this in detail. I'll skip the CT part also because it doesn't provide much of the information. Come straight away to multi-parametric MRI, and it can be used in the staging and characterization of prostate cancer. I'll I'll talk about this in a bit detail. Then coming on to the PET-CT, we know that there are various tracers that are being used. The FDG, not very good for the prostate imaging. We have C11 choline and F18 flucyclovine, and then again PSMA PET. So I'll be covering all this in this lecture. Well, how to make it now state of the art? In the emerging era of multimodal treatments for prostate cancer, the knowledge of advanced stage prior to therapy might alter decision making regarding the choice of treatment. I'll take you straight away to multiparametric prostate MRI because it has been proven to be superior to CT and comparable to bone scintigraphy for detection of lymph node and bone metastases respectively. And pre-treatment multiparametric MRI may obviate the need for additional staging imaging. Pirates classification is a must, and all radiologists should follow that, so that it is a common terminology that is discussions are happening between the oncologist, the surgeons, and the radiologist. Structured reporting is a must for all radiologists, and we have newer modalities for PET, such as the gallium-68 prostate-specific membrane antigen (PSMA PET), and it has been shown in studies to more accurately stage cancer recurrences and facilitate personalized treatment for such patients. This table actually compares all the imaging modalities that we commonly used, be it ultrasound-based, the MRI and the ultrasound fusion, and the PET-CT. We know that ultrasound is office-based, easily available. However, there is limited contrast between cancerous and benign tissue. Multiparametric MRI has excellent tissue contrast, however, is expensive and time-consuming. The combination of MRI and ultrasound fusion helps us in guiding biopsies, and it has improved the biopsy pickup rate for clinically significant prostate cancer. And PET-CT again for advanced for staging and recurrence and metastatic spread. We have various radio tracers that are being used in such patients. This table talks about correspondence of cancer characteristics to imaging modalities. In terms of studying the anatomical features, we have the T2 weighted MRI images and the ultrasound beam mode. For increased cellular density, whenever there is a cancer, it has more cells clumped together. So these would show diffusion restriction and low ADC, and real-time elastography is also coming up on ultrasound for assessment of stiffness. Whenever the tumor is there, it would have increased blood supply. This would be picked up on dynamic contrast enhanced MRI, contrast enhanced ultrasound, and Doppler ultrasound. Changes in cellular activity are picked up on magnetic resonance spectroscopy, the FDG PET, other tracers such as choline and acetate, and PSMA PET for such patients. Coming on to ultrasound-based imaging, grayscale ultrasound is the truss ultrasound that is being used. The Doppler ultrasound improves specificity, and a paper talks that in experienced hands, the use of color Doppler and particularly power Doppler may improve the specificity of lesion-directed biopsies compared to grayscale ultrasound. We have contrast-enhanced ultrasound and real-time elastography that are coming up to improve the specificity further. Within the current standard of care, truss is used largely to guide biopsies rather than to identify the location and extent of tumor. Coming on to the multiparametric MRI straight away, it is used to stage the extent of prostatic cancer once the diagnosis is established. It is used for MR-guided biopsies and to identify the presence of recurrent diseases following treatment. Also to look for patients who have persistently raised PSA with repeated negative truss-guided biopsies. Coming on to the basic concepts, this is how a prostate would look like on an MR also. I will show the images in subsequent slides. And we know the peripheral zone has the maximum glandular tissue, then comes the central zone, then the transitional zone, and the anterior fibromuscular stroma. These are the two neurovascular bundles. This is how the prostate looks like on a normal T2 weighted MR images. We have the peripheral zone, the transitional zone, the capsule of the prostate, the neurovascular bundles on the anterior posterior lateral aspect, the bladder, the levator ani, and the seminal vesicles superiorly. So briefly, the various sequences, how they help us. T1 weighted images help us in detection of hemorrhage and detection of nodal and metastases, especially after contrast enhanced MRI. The T2 weighted images are the most important for zonal anatomy and assess abnormalities, seminal vesicle invasion, extracapsular extension, and nodal involvement. The diffusion weighted images, cancer appears as bright hyperintense, and on ADC maps, it appears as hypointense dark spots. ADC values have been found to predict cancer aggressiveness, and ultra-high B-value diffusion-weighted images, where the value is more than 2,000 seconds, provides better determination of index lesions. So this actually this picture actually shows the ADC, the diffusion, and the T2 weighted images side by side. I'll take you straight away to the most suspicious one on the bottom side. So on ADC, it would be black, the hypointense. On diffusion, it would be white, hyperintense. On T2 weighted images, again, the loss of it would be hypo, and the normal peripheral zone would look like hyper, and this would be hypo on T2 weighted images. The dynamic contrast enhanced imaging on MR, we can do it qualitatively, semi-quantitatively, and quantitatively also. And cancers would show focal and early enhancement corresponding to the suspicious finding on DWI and ADC images. And if it would be negative, there would be no early enhancement, and diffuse enhancement, which would be not corresponding to a focal finding on DWI images. MR spectroscopy is something that can again be used, and we know that the prostatic cancers, they have increased choline and decreased citrate. So this is how a normal MR spectroscopy in a normal prostate will look like with a citrate peak. However, whenever there would be a cancerous growth, the choline and the creatine peak will be higher and citrate would be lower. So a choline plus creatine by citrate ratio more than 2 is highly suggestive of malignancy. Though it has limited clinical application for initial diagnosis, it is mainly used for staging and detecting radiotherapy recurrences. Bone scan, we know that disease parameters can be very useful in selecting the appropriate candidates for bone scan, as the yield of the study will be quite low in the majority of the patients. Why? Though bone scan remains the standard of identification of osseous metastases, the technetium 99 labeled diphosphonate is the isotope of choice. Mets on bone scan can often precede radiographic abnormalities by up to 4 years. However, a median PSA level at which men with prostate cancer develop bone metastasis is 40 nanogram per ml. That is why it is important to actually identify which patients would actually benefit most from the bone scan. PET-CT has limited capacity for initial prostatic cancer diagnosis. It is more widely used for cancer staging, assessing the biochemical failure after radiotherapy, and metastasis involvement. We know that FDG PET is not suitable for prostatic cancer because prostate is close proximity to bladder that confounds the uptake readings. And normally the prostatic cancer cells have relatively weak glucose metabolism. That is why they don't pick up FDG that well. And there's a significant overlap with normal tissue and BPH also. Coming on to the prostate-specific membrane antigen, the PSMA antigen, it is normally expressed in epithelial cells within the prostate and is strongly upregulated by all stages of prostatic cancer. An increase in PSMA expression has been associated with increased tumor aggressiveness, metastasis, and disease recurrence. The commonly used PSMA ligand that we use is the gallium-68 one. And it is, however, there's a catch here. It is also expressed by lacrimal glands, salivary glands, and proximal renal tubules, small intestine, and even neovasculature of thyroid and renal neoplasms. So this table actually talks about all the radiopharmaceuticals that are commonly used in the PET-CT. And we have the C11, the choline one, and the F18 choline. They can be used very well for the soft tissue and the bone disease pickup. However, the disadvantage is that you need to have a cyclotron on site because these are short-acting radiopharmaceuticals, and they have limited sensitivity for liver metastases. That is why most commonly used one is the gallium-68 PSMA1. It has high sensitivity in nodal disease and promising detection rates with low PSA also. So that is something that is very important. Coming on to the PIRATES, it is a prostate imaging reporting and data system. The latest version is a 2.1 that has come in 2019. And I'll skip on these technical details. However, the main objective is that to establish a minimal acceptable technical parameters for multi-parametric MRI, standardize radiology reports to enhance communication with referring physicians, facilitate use of MRI data for targeted biopsy, and develop categories that summarize level of suspicion. These are the different assessment categories from PIRATES 1 to 5, depending upon from very low index of suspicion to very high index of suspicion for the prostatic cancer. This is a reporting template that I was talking about in the starting of my talk. This has been provided by the American College of Radiology, and I strongly encourage all radiologists to follow this because this will give that standardization in terms of how the prostatic cancer MRIs are being reported. And it talks about all the parameters that a radiologist should look into and further subsequently decide. Coming on to the advanced stages of prostatic cancer, we know that the advanced stages are the locally advanced or metastatic disease. However, the management has changed substantially with the availability of multiple effective novel treatments, which has led to improved disease survival. And in the era of personalized cancer treatments, more precise imaging may help physicians deliver better care. The role of imaging in advanced stages are mainly to help in more accurate local staging, because this will define the presence of an extent of tumor, the early detection of metastatic disease, accurate identification of oligometastatic disease. This is very important. Enabling imaging targeted metastatic disease sampling, depicting disease response, and early detection of treatment failure. The frequency of imaging assessment would be guided by the prostate cancer state, whether it's a hormone sensitive or castration resistant, the anatomic location, and extent of metastatic disease. According to ASCO, one or more of the following imaging modalities should be used for patients with advanced prostate cancer: the conventional imaging that include a CT or a bone scan or a prostate MRI, or a next generation imaging, the NGI, which they call, which includes a PET-CT, a PET MRI, or a whole body MRI. In cases in which salvage radiotherapy is being considered, the next generation imaging should be offered, whether it is a PSA imaging, a choline or a fluciclovine PET-CT or a PET MRI, whole body MR, or even F18 sodium fluoride PET CT, because they have been shown to have superior disease detection performance characteristics and may alter patient management. The volume of disease at presentation and during initial biochemical recurrence and biochemical failure while undergoing systemic therapy are highly prognostic, affecting therapy options. That is why it is important to quantify the volume of disease. And in patients with only less than 5 demonstrable sites of metastatic disease, called the oligometastatic disease, more aggressive metastatic directed treatments can be considered, such as targeted radiation therapy, surgery, or local ablative procedures. Therefore, imaging plays a relatively minor role if patients are responding clinically and with in whom with blood biomarkers which are normal with the hormone sensitive states. CT and bone scanning have limited ability to depict the heterogeneity of response behavior of metastatic and nodal disease, thereby contributing to treatment failure and poor patient outcomes. In terms of metastatic nodal disease, imaging has been used to guide nodal dissections to suspicious sites outside the normal surgical field. We can either use a CT, MRI, or a PET CT, and gallium-68 PSMA PET has shown higher sensitivity in the detection of nodal disease, better than a CT or a MRI also. Second generation 18F labeled PSMA directed radiopharmaceuticals have longer half-life. They have a different biodistribution kinetics and higher spatial resolution than the gallium-68 one PSMA one. So this is a patient in which a whole body PET MRI, a choline PET MRI was done, and these are coronal images. And you can see on a T1 weighted images there is a lymph node over here, which is showing restriction on the diffusion weighted images, and which is showing increased choline uptake on the fused images, thereby picking up such a small node also. Coming on to the bone metastasis, we know the standard bone scan and CT can be used for such patients. However, the technetium 99 bisphosphonate bone imaging is currently the most widely used method to evaluate bone metastasis in presence of bone metastasis in patients with prostate cancer. However, the early metastases can be confined to the bone marrow itself and may not show tracer uptake, thereby limiting disease detection. Whole body MRI is something that is picking up very well, and in combination with multi-parametric MRI of the prostate, it may actually be a one-stop shop whereby only one imaging modality can be used in patients to pick up both the local prostate cancer, its local staging, and look for metastasis elsewhere also. After the PIRADS, even the MET-RAD-SP, the metastasis reporting and data system for prostate cancer is coming up to standardize reporting in the whole body MRI also. And again, PET CT and the PET MRI can be used for bone metastasis. So this is one patient. The first two images are the normal bone scan, and this is a whole body MR. So this is a patient with castration-resistant prostate cancer and was receiving anti-androgen targeted therapy and has a rising PSA level. In such patients, bone scan, especially in castration-resistant prostate cancer, patients can be fallacious and might not pick up all the lesions. And these are the two images, the anterior and the posterior view, and compare this with the whole body MR. This is how the extent of disease is being picked up on the whole body MR with so many bone metastases which were not picked up on the bone scan. Is all the things. So I started with NCCN. So again, this table actually gives you both NCCN and the EAU, the ESTRO and SIOG guidelines. So for patients with low risk group, NCCN only says that consider multi-parametric MRI if aggressive cancer is suspected when PSA increases or systemic prostatic biopsies are negative. For intermediate risk group, NCCN talks about, again, I talked about how if the nomogram predicts more than 10% probability, then the cross-sectional imaging should be taken. And bone scintigraphy, again, for the intermediate group, not favorable with less than, in a subset of patients with less than 50% of biopsy course. For high risk, again, cross-sectional imaging is recommended and bone scintigraphy is recommended. And for locally advanced prostate cancer, again, the cross-sectional imaging is recommended, and similarly bone scintigraphy also. In terms of biochemical recurrence, either a post-radical prostatectomy or a post-radical radiotherapy, the guidelines say that they vary as per the in terms of NCCN. They talk about a whole body PET CT or a whole body PET MR, and a normal routine chest X-ray, CT, abdomen pelvic CT MR, and bone imaging. However, as per the EU guidelines, if the PSA is less than 1, they say that no imaging is recommended, and if PSA is more than 1, PET CT is recommended, either a choline or a PSMA scan. Similarly, post-radiotherapy, again, in a patient where the PSA is increased by more than 2. So they talk about how MR should be used in such patients. So these are the guidelines that can be readily used for follow-up of patients. In terms of recurrence, for what does NCCN talk about? NCCN talks about that whenever there's a PSA persistence or recurrence, again, a chest CT, bone imaging, abdominal pelvic CT or a abdominal pelvic MR, or a whole body PET CT either with a choline or a PSMA can be done, and prostatic bed biopsy if imaging suggests local recurrence. Again, this for post radiotherapy recurrence. Again, similar guidelines are made by the NCCN for evaluation of such patients. Well, that brings an end to my talk in terms of how the state-of-the-art imaging should be done for patients who present with prostate cancer initially and post-recurrence. And this is, again, I've taken this snapshot from the same publication by the Johns Hopkins University. And this is how they talked about that every man needs this book and a guide to surviving prostate cancer. Not just talks about what prostate cancer is, but a good read for all such patients. Thank you so much.